This is the Group C presentation for MPH-606. Our group is Gull, Brandi, McCann, and Melissa Wedel. Our research topic is acute flaccid myelitis, or AFM. Acute flaccid myelitis is a very rare disease, but it is also a very serious disease. While it is not polio, it does produce a polio-like illness in the gray matter of the spinal cord. AFM causes paralysis primarily in children and appears to come in clusters every other year. The next anticipated cluster is expected to happen in 2020. AFM symptoms include sudden weakness in extremities, slurred speech, difficulty swallowing, facial weakness and/or drooping, headache, bowel or bladder changes, difficulty breathing, weak or lost reflexes, and neck or back pain. The cause of AFM is unknown, but it has been linked to a viral etiology, specifically enteroviruses, West Nile virus, and adenovirus. Recent research strongly suggests a correlation with two enteroviruses, EVD68 and EVA71, with researchers focusing on EVD68. This is because most patients with AFM, greater than 90%, had a respiratory illness or fever that is typical with a viral infection prior to development of AFM. Viral infections in children are very common and most recover, but a small percent develop AFM. According to the CDC, there have been 590 confirmed cases of AFM since the CDC began tracking cases in August of 2014. AFM cases appear to have onset between August and October and increases in cases every 2 years. While it mainly affects children under the age of 18, the average age of AFM patients is 5. And AFM produces a potential burden of lifelong disability for the affected child and for their family. On the slide, you see a data visualization from the CDC, and it is a bar graph. The bar graph shows that there have been 590 confirmed cases of AFM since the CDC began tracking cases in August of 2014. AFM cases appear to have onset between August and October, which you can see on the graph, with an increase in cases every other year since 2014. The burden of AFM relates to who is most impacted, and that is children under the age of 18. And although rare, AFM affects these children and devastates their lives and their families' lives. With the pattern of cases increasing every 2 years and the exact cause or factors not known, makes this a critical public health problem. The literature review provides introductory details about AFM, and this disease has only been tracked since 2014. According to Sager et al., a report in 2014 on 2014 nationwide surveillance did not find a specific etiology or pathogen for AFM. And again in 2015, a year after nationwide surveillance, AFM etiology remained a mystery, although there is some evidence that a virus might be responsible. Progress has been made since these studies, and the identification of a probable cause of AFM has been established. In several articles, a correlation between AFM and EVD68 were found, with significant correlation in areas with spikes of EVD68 and clusters of AFM. While only a few AFM patients tested positive for enterovirus and cerebrospinal fluid, antibodies for EVD68 were found in many patients' respiratory specimens. Enterovirus is a common virus found in several children with respiratory infections, leading to a gap of why only certain children develop AFM. The only clue found that is unexplored is that of asthma cases and family history of asthma seen in children who have symptoms of an enterovirus and then go on to develop AFM. A study performed by Schuster et al. Found in their sample population of 68 AFM cases that 68% had a history of asthma or recurrent wheeze. This is an important gap to explore through research. Our research question asks, what is the correlation between patient and family history of asthma and true AFM cases? It is important to be sure that AFM is diagnosed per CDC guidelines to ensure true cases are being measured. CDC guidelines define a true case of AFM as an illness with onset of acute flaccid limb weakness and a magnetic resonance image or MRI showing spinal cord lesions largely restricted to the gray matter. The aim of the research is to find a correlation between a history of asthma and contracting AFM after viral exposure. The proposed study design is case control, and it is case control because AFM is rare and there aren't many confirmed cases. Comparing cases and non-cases will be helpful in making further correlation in cases or causes of differences in those children who develop AFM after viral exposure and those who do not. The population of interest for our study will be children under the age of 18 who are diagnosed with AFM per CDC criteria. We will be submitting a full board review IRB application because the participants are minors, as well as sensitive medical information will be collected for our study. The implications of this research include distinguishing between why a child with enterovirus, particularly EVD68, might get AFM versus a child who does not get AFM. It could help to identify a high population risk or high risk population. For example, children under the age of 18 with asthma, and also help identify a population group that could be good candidates for a vaccine trial down the road. Our cases will be children with newly medically diagnosed AFM per CDC guidelines who are under the age of 18. Inclusion criteria are children under the age of 18 with confirmed positive results for EVD68 and medical testing which supports AFM diagnosis. The exclusion criteria includes children who are 18 years of age or older, who have no parental consent or no medical diagnosis confirming AFM. Children will also be excluded if they have had central nervous system trauma, central nervous system malignancy, or any other underlying central nervous system condition, which could confound the results. The control group identified as the exposure must be under 18, have parental consent, be at the identified exposure site, have developed respiratory illness due to EVD68 within 2 weeks of the patient AFM onset. The exclusion criteria for this group include the participants being 18 years or older, having had no respiratory illness, or who do not have parental consent. AFM is rare and with rare outcomes, so for this reason, sampling would be through non-probability sampling, particularly convenient sampling. We will be identifying newly diagnosed and reported cases of AFM in 2020, followed by interviews with parents or guardians at the AFM patient's potential exposure site, which will include school, daycare, church nursery, or regular playgroup. Sampling and data collection can only begin after informed medical consent for each minor child is obtained, as well for parents or siblings that may have their information collected or be interviewed, and if informed consent cannot be obtained, the individual must be excluded. For parents of newly diagnosed AFM patients, medical histories and demographics would also be collected along with making sure obtaining informed consent happens prior to any data collection or interview process. The order of recruitment would be identification of newly reported medically diagnosed AFM cases, contact with the hospital or provider that reported the new AFM case, obtaining necessary informed consents of minors, parents, and any siblings, and after conducting data collection regarding new cases and their family, reach out to the exposure site if applicable. Contact exposure site, which could be a school, daycare, church, playgroup, organizer, and inform them of the necessary data collection and obtain informed consent from the parent or guardian of any child meeting criteria for inclusion. Once informed consent is obtained, data collection will be made through detailed phone interviews based on descriptive statistics and detailed medical history after the confirmation of the patient meeting inclusion criteria, the parents of the patient, and any sibling of the patient. Asthma diagnosis and asthma severity will be determined by the physician, as well as any list of asthma medications that the patient may be on if they do have asthma. AFM must be diagnosed medically per CDC criteria, and a diagnosis of EVD-68 will be made through saliva and stool tests. It is important to note pleocytosis because it is suggestive of inflammation. The exposure group. The exposure site will be identified in the interview with the parents of the AFM patient, and the site will be contacted in order to explain the need for data collection and to obtain informed consent. Once informed consent for each minor child and parents are received, telephone interviews can be conducted in order to gather the necessary data. We will also need consent to medically verify any potential asthma diagnosis and history with a family doctor or pediatrician. On this slide, you can see a table of the descriptive statistics that will be collected, and they are going to include demographics and specific medical history information regarding asthma diagnosis, severity, medical use, and any exacerbations within 2 weeks prior to medical diagnosis. For the AFM patient, as well as any siblings of the AFM patient or children in the EVD-68 exposure cluster, we would be collecting whether they're male or female, the age, the ethnicity, whether or not they are medically diagnosed with asthma, the severity of the asthma medications, if they have asthma, and whether or not, if they have asthma, they had had any exacerbation within 2 weeks prior to the patient diagnosis of AFM. And that includes the patient, any siblings, or any children in the exposure cluster. The mother and father of the AFM patient, if applicable, would be asked their age, whether or not they are medically diagnosed with asthma, the severity of their asthma, and asthma medications if they are indeed diagnosed with asthma. To account for confounders, the method of stratification would be used. Stratification allows for groups to be established in which the confounder does not vary. Within the phone interview process, sex, ethnicity, and age will be asked of each participant. Evaluation of the exposure outcome within each strata will be established. Using the Mantel-Haenszel test as adjusted relative risk for each stratum is determined. If there is a difference between the adjusted and unadjusted relative risk, confounding is likely. Qualitative data could be valuable to our work because it could give detailed descriptions of medical histories and recent illness criteria that may be overlooked without qualitative data collection. It could also offer insight into similarities in exposure sites that might not be identified in quantitative data, such as detailed infection control practices at exposure sites, EVD-68, and asthma prevalence at control sites, and simply identifying an unknown variable that has not yet been considered due to the low number of cases, and therefore a lack of good qualitative data about the exposure and the patients affected by AFM. Our sample will be children under the age of 18 diagnosed with AFM. Controls will be children under the 18 with respiratory illness from EVD-68, which will be recruited from venues that have been identified to have had outbreaks of EVD-68 in the 2 weeks preceding onset of AFM illness in the patient. The recruitment approach for the affected patients will initially be through newly reported cases in 2020. Parents or guardians of the reported cases will be contacted in order to obtain consent for access to medical records and to participate in the interview. The recruitment approach for the control group will be to identify the potential exposure site and find children with recent EVD-68 respiratory infection within 2 weeks of the diagnosis of the patient or case and reach out to the site director or facilitator to get contact information in order to obtain informed consent. Much of the issue with the control group, and to some extent the cases, is to ensure initial qualitative interview is descriptive enough to ensure inclusion of participants based on the inclusion and exclusion criteria. The qualitative data will be collected using multiple sources such as interviews and documents, for example, medical records and history. And once new AFM cases are identified through reporting sources, assurance that patients meet the inclusion criteria and informed consent will be obtained. The qualitative data collection would begin with the patient's medical charts and history and then progress to the interview of the parent or guardian of the patient. After identification of the exposure site from the case's interviews, informed consent will be obtained in order to interview the parents or the guardians of the control cases. Consent for recording the interview would be included in the consent forms before the interview process. The interviews will be transcribed to ensure accuracy of the information and that details are not missed. After the interview, transcription, and review, it may be necessary to go back and clarify information or to ask additional questions to get complete clarity. Interviews will be conducted in person if possible, but more than likely over the phone due to costs. Of the different qualitative methods, the case study method is most applicable for this study. The focus of the case study qualitative method is organization, entity, individual, or event, and the qualitative data collection will be interviews and documents, medical records and histories. Before we interview the parents, we will be explaining basically what we're asking them to answer and giving them some directions on how to answer the questions, along with prompts in order to get the best detail possible. As you can see, we ask many questions about symptoms and onset, locations, and various other things, and we ask detailed descriptions of any asthma history, flare-ups, medications, and other details about illness. And these would then be confirmed through medical diagnosis that would be covered under the informed consent. Also, prior to ending the interview, we would be asking the parents for the best number to contact them for follow-up questions and the best time and day. The follow-up interview would have been covered in the informed consent at the beginning, prior to beginning the interview, so that after the transcript is reviewed, we could go back and clarify anything that remains unclear or that raised another question for us. A deductive approach will be used to analyze the data obtained from the interviews and from the medical documents. Predetermined structure ensures continuity through the interview process, and the structure ensures complete historical, significant events, exposures, and exposure locations that cannot be obtained through analytical data collection. The analysis to be conducted will be to analyze the data from the interviews and the medical documents to better understand the correlation or lack of correlation between EVD-68 illness and the development of AFM, and whether or not asthma, especially the severity or a recent exacerbation, may have played a role in which children developed AFM and which children did not. And it could also lead to potential alternative exposures. Thank you so much for your kind attention.